Good morning, ladies and gentlemen. I'd like to thank the organizer for inviting me to this wonderful meeting. I'd like to give you an overview into the research field that we are most interested in, and this is the disease called peripartum cardiomyopathy. Peri- or postpartum cardiomyopathy is a disorder of unknown etiology in which symptoms of heart failure occur between the last months of pregnancy and 5 months postpartum in previously healthy women. The incidence of this disease varies among different geographic regions. It's estimated to be about 1 in 1,400 up to 1 in 3,500 pregnancies in the US and in Western Europe. It's much more frequent in Africa. There are regions where we have 1 in 100 pregnancies. In South Africa, where the disease is well studied, it's an incidence of 1 in 1,000 pregnancies. And another hotspot has been reported in Haiti, where we see about 1 in 300 pregnancies. Typical for this disease is the rapid progression. End-stage heart failure is often achieved already 1 to 6 months after the first diagnosis. At present, postpartum cardiomyopathy is listed as a form of dilated cardiomyopathy, and it is treated according to the guidelines for dilated cardiomyopathy with no specific therapy. The treatment includes normally ACE inhibitors, beta blockers, vasodilators, and diuretics. Nevertheless, despite this optimized treatment, we have mortality rate or transplantation rate of about 10 to 25%. We have started a registry for postpartum cardiomyopathy patients in Germany with, meanwhile, about 100 patients. And we see also in Germany about 30% of women that die or that have to undergo transplantation. Improvement, which is not recovery, but at least getting better, is seen in about 50% of patients, and full recovery is taking place in less than 30% of patients, is also quite consistent as we see in the postpartum cardiomyopathy patients in Germany. Little is known about the pathophysiology behind this disease, and therefore we were quite happy when we discovered that one of our transgenic mouse models that actually lacks a transcription factor STAT3 only in cardiomyocytes develops symptoms that are quite similar to the disease seen in patients. These female mice are completely happy and well as long as they're not breeding. When we start breeding, they display a high incidence of postpartum mortality, which is increasing with the number of pregnancies that they undergo. The histology shows that most of these mice have a severe dilatation of all ventricular chambers, often associated with thrombi and strong fibrosis, and all is associated with a decrease in systolic function. We have carefully evaluated the phenotype of these mice, and the most striking thing we observed was a defect in the vasculature. As you probably all know, during pregnancy, the maternal heart undergoes hypertrophic growth in order to compensate the increased workload, and this is associated with an increase in vessel density. We see this increase in wild-type mice as well as in a knockout mice. In the early postpartum phase, the wild-type mice are able to maintain this increased capillarization, while we see a rapid decrease in capillary density in the knockout females, which is also quantitatively shown in this bar graph. What could be responsible for this defect in the vasculature? And we pretty soon looked into the hormonal changes that are present in women, especially at the time of birth. During pregnancy, it's known that estrogen levels and progesterone, for example, steadily increase but rapidly decrease just at term. Other hormones, as prolactin, for example, are higher in pregnant women as well, but continue to increase in the early postpartum phase. We specifically looked at prolactin, which is a member of a growth hormone family responsible for the coordination of a wide range of biological processes. For example, it's involved in fertility processes. It's the lactation hormone. It It's promoting tumor growth. It plays a role in immunity and inflammation as well as in hemodynamics. Prolactin can act as a classic endocrine modulator via entry into the circulation or locally through juxacrine and paracrine as well as autocrine modes of action. Upregulation of prolactin under physiological and pathophysiological conditions are known. It's not only in pregnancy and postpartum, but also patients with prolactinoma after trauma and injury, after large surgical interventions, some patients with breast cancer, patients that are undergoing estrogen therapy or are taking antipsychotic drugs may face increased systemic prolactin levels. Prolactin is a hormone with many phases. If we come back to the angiogenesis or the vasculature, prolactin or the full-length prolactin is quite a strong proangiogenic factor that is promoting proliferation and survival of endothelial cells. It's also increasing their motility, and in fact, it's really promoting angiogenesis. However, this full-length prolactin can be cleaved proteolytically by a protease called cathepsin D in a 16 kilodalton N-terminal fragment that actually does exactly the opposite. The 16 kilodalton prolactin fragment is inhibiting endothelial cell proliferation. It's inhibiting the migration of endothelial cells. It actively induces apoptosis of endothelial cells, and it is even able to disrupt already formed capillary structures. Furthermore, it interferes with endothelial calcium transients and thereby disturbs vasorelaxation. When we went back to our mouse model, we exist hearts of wild-type and knockout females at the end of pregnancy as well as in the early postpartum phase and generated extracts from these hearts and added the full-length 23 kilodalton prolactin to these extracts. Only in a postpartum in heart extracts from postpartum knockout females, we were able to see the cleaved 16 kilodalton prolactin form. It was not present in extracts from postpartum wild-type hearts or in extracts from wild-type and knockout hearts at the end of pregnancy. The cleavage was clearly dependent on cathepsin D activity because it could be completely blocked by adding the cathepsin D inhibitor pepstatin A to the heart extracts. We also discovered that in the stat3 knockout hearts postpartum, we see an increased expression of cathepsin D. Cathepsin D is normally, or is actually present in all cells, but it is present in an inactive form that is kept in the lysosomes. In the postpartum knockout hearts, we see that it is actually released from the lysosomes. It's present in the cytoplasm, and it also can be detected in the extracellular spaces. What does the 16 kilodalton prolactin to the heart? To test this, we used an adenovirus that is expressing only the 16 kilodalton prolactin form, and we injected wild-type non-pregnant females with this adenovirus as control. Females were injected with an adenovirus that is expressing the bacterial gene LAC-Z that is biologically neutral. 2 weeks after injection, we found a severe decrease in capillary density in the hearts that were expressing the 16 kilodalton prolactin form, and this is not the case in the hearts that are expressing the control virus. This is shown here quantitatively as well. Furthermore, after 2 weeks, the systolic function in the females that are expressing the 16 kilodalton prolactin in the heart is decreased, and we see a beginning dilatation of the hearts. In vitro analysis showed that the 16 kilodalton prolactin did not interfere with cardiomyocyte survival, but it reduced metabolic activity and it interfered with contractile activity. It actually decreased contractile activity of cardiomyocytes in culture. To summarize so far, what we've seen is that in a stage where postpartum the transcription factor STAT3 is low, we get a cleavage of the 23 kilodalton full-length prolactin in a 16 kilodalton subform, which is on one hand, reducing metabolic activity and contractility of cardiomyocytes, and which is promoting apoptosis and dissociation of capillary structures, as well as vasoconstriction and inflammation, is a point to which I come a bit later in this talk. Now, what is responsible for the activation of the prolactin cleavage, or the cleaving enzyme cathepsin D? It is known, for example, that oxidative stress is a strong trigger for cathepsin D activation in cardiomyocytes. If we look in the physiology of normal pregnancy, it is known that oxidative stress actually rises during pregnancy and culminates in the last trimester. This is normally paralleled by an increase in total antioxidant capacity, which rises a little bit later and peaks in the early postpartum phase, suggesting a need for a very efficient antioxidant defense mechanism late in pregnancy and postpartum. There is where we think that STAT3 probably plays a role because it's one of the transcription factors that is responsible for upregulating antioxidant defense mechanism, for example, by increasing the expression of antioxidative enzymes such as the manganese sodium dismutase. Indeed, wild-type postpartum hearts show an increased expression of MNSOD, which is attenuated in the STAT3 knockout hearts. This is associated with an increased production of superoxide radicals in the postpartum knockout hearts compared to the wild-type hearts. Is this a central part of the pathophysiology of postpartum cardiomyopathy in the STAT3 knockouts? To test this, we treated these females with a so-called MNSOD mimeticum. It's MMT-PEP. We injected these females in 2 subsequent pregnancies and actually could show that this increase in SOD activity in the STAT3 knockout hearts prevented the loss of capillary from the hearts, it improved cardiac function, and it largely rescued the postpartum mortality in the STAT3 knockout females. So that we can add to our scheme now that the low expression or absence of STAT3 is interfering with an efficient antioxidative defense mechanism in the maternal heart postpartum. If this is not present, we get an increase in radical production, which actually is responsible for activating cathepsin D, which is then subsequently cleaving prolactin in its detrimental 16 kilodalton form, with all its negative effects on cardiomyocytes and on the vasculature. Based on this data, we came up with the hypothesis that the generation of 16 kilodalton prolactin from the 23 kilodalton full-length prolactin is responsible for the development of postpartum cardiomyopathy in the STAT3 knockout mice. If this is true, inhibition of prolactin secretion should eliminate both prolactin forms, and subsequently no postpartum cardiomyopathy should develop in the STAT3 knockout model. To test this, we used bromocriptine, which is a pharmaca that is used in patients since a long time to stop lactation in women that cannot or do not want breastfeed, or also to treat patients with prolactinoma. Indeed, this bromocriptine treatment completely prevented the decrease in capillary density in the STAT3 knockout hearts, here also shown graphically. And in fact, it completely prevented the onset of postpartum cardiomyopathy. All STAT3 knockout females that were treated with bromocriptine survived. They didn't show any sign of dilatation, no sign of fibrosis, and they could maintain their systolic function. So that we add further to our scheme that simply preventing the release of prolactin seems to completely prevent the onset of postpartum cardiomyopathy in our STAT3 knockout mouse model. Now, we were wondering, by looking at the patient, whether we have different forms of postpartum cardiomyopathy. Especially what was kind of obvious is that we have patients that face a more inflammatory type of postpartum cardiomyopathy, and we have patients that have absolutely no signs of inflammation. We have a collaboration with South Africa, with Karen Sliva, who treats many postpartum cardiomyopathy patients that are coming from the region of Soweto. All these patients have a high degree of inflammation, for example, shown by an increased expression of inflammatory cytokines and CRP. We looked in these patients and were wondering whether the inflammatory status had any predictive value. We divided the patients we retrospectively analyzed the patients in terms of whether they were able to improve spontaneously their ejection fraction by more than 10% or whether they were not able to improve the ejection fraction. And we looked in a time frame of 6 months on the kinetics of several serum markers in these patients. Interestingly, we found a correlation of OX-LDL with anti-proBNP, of interferon gamma, which is a strong pro-inflammatory cytokine with anti-proBNP, and prolactin with anti-proBNP. And all these markers also correlated with each other. So that it seems that the correlation of anti-proBNP, OX-LDL, prolactin, and interferon gamma points to an inflammatory component of postpartum cardiomyopathy, which seemed to revert among improvers, while it may progress into chronic inflammation in non-improvers with a poor prognosis. Inflammatory mechanisms have been looked at in postpartum cardiomyopathy, but are not really well understood. There is a theory that myocarditis may be a trigger for postpartum cardiomyopathy, but often there is no virus load present in biopsy of these patients. Autoimmune components are discussed. Autoantibodies have been discovered in some postpartum cardiomyopathy patients. Systemic infections are present also in some, but not all, patients. And also mother-fetus incompatibility have been discussed, but for this theory, so far there has no evidence been presented. When we look in our German registry, what is obvious that we have a lot of patients with postpartum cardiomyopathy that are obese, and among these obese patients, about 90% show the more inflammatory type of the disease, with CRP elevated in more than 90% of these patients. From the experimental data, it is known that the 16 kilodalton prolactin has some aspects of inflammation. It, for example, triggers the expression of inflammatory factors in endothelial cells. It can promote the adhesion of leukocytes to endothelial cells, and we found that when we express 16 kilodalton prolactin massively in the heart, it actually induces the invasion of inflammatory cells to the heart. Taking the data from the patients, we were wondering whether a metabolic parameter maybe accelerate this inflammatory phenotype in postpartum cardiomyopathy. For example, insulin growth factor, which is increased in most obese patients. If we combine 16 kilodalton prolactin and insulin growth factor in stimulating cardiomyocyte, we see that this markedly increased the expression of pro-inflammatory factors such as MCP1 and CXCL2 from cardiomyocytes. So that we thought that maybe the IGF pathway is responsible for the inflammatory type of postpartum cardiomyopathy. And it is known that IGF is a strong activator of AKT signaling. To test this hypothesis, we crossed into the STAT3 knockout model a AKT transgene, which is only expressed in cardiomyocyte, to generate a situation where we have no STAT3, but we have an accelerated activation of AKT signaling. Indeed, this combination led to a dramatic increase in the postpartum mortality in the mouse model. Interestingly, the surviving double transgenic mice did not display a severe reduction in systolic function compared to the individual transgenic models, compared to the STAT3 knockout alone or compared to the AKT transgenic mouse alone. So that and severity in systolic in decrease in systolic function is not present. Also, there is no increase in fibrosis in the double transgenic model, despite they show this markedly enhanced mortality. However, what we observe is that the double transgenic now have massive inflammatory infiltrates in the hearts, almost generating a phenotype of myocarditis. We were wondering whether the blockade with bromocriptine, which worked so efficiently in the STAT3 knockout model alone, was also effective in preventing the disease in this double transgenic inflammatory model. Indeed, the bromocriptine treatment reduced the inflammatory status of the double transgenic mouse to a substantial degree, and it actually was able to prevent the postpartum mortality in this inflammatory model of postpartum cardiomyopathy. So that we can add an inflammatory component to the postpartum cardiomyopathy, which actually is responsible for a worse prognosis. Now, how do our experimental findings that we have discovered in STAT3 knockout mice mainly relate to the human form of postpartum cardiomyopathy? Again, in collaboration with Karen Sliwa from South Africa, we were able to analyze serum probes from patients with acute postpartum cardiomyopathy and compare them to postpartum women that were healthy. And as you can see here in this bar graph, ox-LDL levels were markedly increased in women with postpartum cardiomyopathy compared to the healthy women. Cathepsin D activity was markedly increased. We had very few biopsies from patients with acute postpartum cardiomyopathy that showed that there is an increase in expression and release of cathepsin D. Total prolactin was markedly increased in patients with postpartum cardiomyopathy, and only in these patients we were able to detect the 16 kilodalton prolactin form in the serum, while normal, healthy nursing women do not show this cleaved form of prolactin. Based on this data, Karen was willing to try a pilot study. Meanwhile, we treated some patients in Germany as well, so that we have 18 patients that had presented with a subsequent pregnancy after a previous postpartum cardiomyopathy, which puts them at a very high risk to develop the disease again. 6 patients were put on standard therapy, ACE inhibitors and beta blockers, and meanwhile 12 patients obtained, in addition to the standard therapy, the bromocriptine treatment. In the control group, 3 patients died within a 4-month period, and the surviving 3 patients remained in severe heart failure. All 12 patients treated with bromocriptine survived and maintained normal cardiac function. How is it with patients that present with acute postpartum cardiomyopathy? This is an example of a patient that we've seen in the Hanover Medical School in February 2006. She was admitted to the hospital in severe heart failure with ejection fraction below 20%. We treated her with standard therapy of heart failure and added bromocriptine to this therapy for 8 weeks. In April, she had recovered to 40% ejection fraction. In May, she had over 50%, and she completely recovered. We see her every year for control, and she's doing well. However, I have to mention at this point that we tried to stop the heart failure medication in this patient, and when we stopped this, her cardiac function decreased again. And we see this in many of the patients that have recovered completely normal function. When we stop the heart failure medication, they seem not to be stable. We also have the results from a first randomized study with 20 patients with acute postpartum cardiomyopathy in South Africa. The inclusion criteria were that they have all to be diagnosed in the first postpartum months, they had to be HIV negative, and the observation period was 6 months. They were randomized to 10 patients receiving bromocriptine in addition to standard therapy, and 10 patients that were receiving only the standard therapy of heart failure. At baseline, both groups showed a similar degree of decreased systolic function. 6 months later, the patients that obtained bromocriptine had almost fully recovered, while the patients in the control group remained in severe heart failure. Mortality rate, we had one patient in the bromocriptine group that died. She died in the first week after admission to the hospital. In the standard group, we had a mortality rate of 40%. All patients died later. 2 of them died of sudden cardiac deaths, and 2 of them died in severe heart failure. What I also would like to mention is that bromocriptine has actually been withdrawn from the US market due to a report on thrombotic events. And there are, in fact, some case reports showing that women that were taking bromocriptine to stop breastfeeding were facing acute coronary artery thrombosis or myocardial infarction. However, if I screened the literature more carefully and I find about the same amount of case reports showing myocardial infarction and thrombotic events in women that had not been, or in postpartum women that had not been treated with bromocriptine. In fact, if we look into the normal pregnancy, it is known that there is an increase in the procoagulant activity in the maternal blood characterized by elevation of factor 7, 10, 8 fibrinogen and von Willebrand factor, which is maximal around term and which is probably needed to prevent extensive bleeding after the birth. In fact, at baseline, that means before any treatment has been initiated, we see ventricular thrombi in about 50% of our patients. Nevertheless, there is evidence or experimental evidence that bromocriptine may increase the thrombotic status in patients. Interestingly, prolactin is also a substrate for thrombin, and thrombin is cleaving prolactin also in a 16 kilodalton fragment, but this time is a C-terminal fragment with no biological activity. Nevertheless, if we deplete prolactin completely out of the system, we may increase thrombin activity for cleaving fibrinogen and inducing the coagulation cascade. Therefore, bromocriptine may, by depleting the prolactin out of the system, may really increase the risk for thrombotic events. And we therefore recommend that patients that are treated with bromocriptine should always be given in conjunction with anticoagulants such as heparin. What are we doing currently? One of the major problems in postpartum cardiomyopathy is that the disease is often overlooked and the diagnosis is late. About 1/3 of the patients that we have in our registry were diagnosed later than 2 weeks postpartum. The diagnosis is difficult. ECGs, as you can see here in these patients, can be completely normal. Nevertheless, this patient, as you see in these MRI pictures, was in severe heart failure. Also, symptoms might be not typical and may be mistaken for just normal problems that are associated with the postpartum phase, such as abnormal fatigue, postpartum depression, dyspnea, difficulties in sleeping, pulmonary edema, as shown here in this patient, arterial or cerebral embolism, tachycardia, and so on. So far, only the echo or the MRI can actually diagnose postpartum cardiomyopathy, and we recommend that all postpartum women that show any of these signs should undergo an echocardiographic analysis. Nevertheless, we would like to make it easier and to have a diagnostic blood test that is available to peripheral physicians or gynecologists, which are the first ones that are seeing these patients. And the theory that we have is that we think that must be some common factors that are present in all postpartum cardiomyopathy patients coming from South Africa or having been diagnosed in other countries. We looked already at some of these markers. We found that, for example, NT-proBNP is markedly increased in all patients in South Africa and in 99 patients that we diagnosed in Germany. Other factors, such as CRP, are elevated in some patients, but not in all. OX-LDL, which was very prominent in the South African patients, is actually not significantly elevated in the postpartum patients in Germany. However, cathepsin D, for example, is another factor that is highly elevated in both patient populations. So that we have two potential candidates so far that may serve as diagnostic markers. It's NT-proBNP and cathepsin D, and we are currently looking for other markers that can be included in this scheme. With this, I'd like to close and thank you for your attention. And I'd just like to make a brief statement. My mentor and former chief in cardiology, Professor Drexler, died 4 weeks ago, and I like to thank thank him for everything that he did and that he also conducted to this project. And I'd like to thank all the other co-workers that we had in this project. Thanks for your attention.